So I joined the BNPA in 27 years ago now, and it was a £15 standing order, very good value at the time. And I spoke at the meeting, the equivalent of this meeting, about 20 years ago. And in preparing for this talk, I realized to my horror that I'd spoken about the same thing. I spoke about illusions, and it led me to think, well, what on earth have I done with my life? But I hope that I can persuade you in the next 25 minutes or so that I haven't done illusions all the time. I have moved on, and the reason I've come back to it now is because of what we've learnt about hallucinations. So, for those of you that aren't familiar with the current hallucination story, just a quick resume. So we know hallucinations, particularly visual hallucinations in neurodegenerative diseases. They're common across a whole range of neurodegenerative diseases, including Parkinson's disease. And when they occur in the context of degenerative eye disease, that's the association that we call Charles Bonnet syndrome that Paul's already mentioned. So they're clinically important because we're realizing now how common they are, how prevalent they are across all of these conditions, and of the high morbidity that they cause. So a lot of these patients at some point in their illness will need some form of treatment for the visual hallucinations. But the real reason, I guess, why they're becoming important is because of what they tell us about future trajectory. They've got two examples here, one from Parkinson's disease, one from Alzheimer's disease, but it's the same across all neurodegenerative diseases, not Charles Bonnet syndrome perhaps, but these brain neurodegenerative conditions. And so the idea is that if you take a group of patients with, say, Parkinson's disease, and you divide them into two groups, one of which has visual hallucinations and the other one doesn't, and then you wind forward the clock 3 or 4 years, you'll find that the ones with hallucinations, that's the red lines, have a much steeper trajectory of cognitive decline. Now, it's not just cognitive decline, there's a whole range of outcomes that are much poorer if you've got visual hallucinations. And on the left of the slide, sorry, the right of the slide here, a famous study that showed a 16-fold increase in risk of moving from living independently into a care home if you have visual hallucinations. And that's this is Parkinson's disease, and it's controlling for level of cognition, and it's controlling for motor impairment. So something about the visual hallucinations that makes that transition. So the question then arises, is this the same? Are these poor outcomes the same for the whole range of visual perceptual phenomena that occur in the context of neurodegenerative disease? And that's really the theme of my talk today, to look at this borderland of hallucination-like phenomena, this margins of hallucinations, and see whether these poor outcomes are true of these as well, and also what we can learn about the underlying mechanisms of these borderland phenomena. So, I mean, we've covered this ground here, but we've had instilled from us from a very early age that a hallucination is the experience of seeing an object in the world, a visual hallucination, seeing an object in the world where no object is present. And of course that is in contrast to the normal day-to-day experience of seeing, where there is a visual object, there is an object in the environment, and we have a corresponding visual experience. Now, what's also been instilled in us is that illusions are something different to hallucinations. So in this case, in the illusion, there's an object in the real world, and we have a visual experience, but it's the wrong visual experience. It's not corresponding in some way. There's some sort of there's a mismatch, or a bigger mismatch than usual, between what's really there and what we're experiencing. So that's we all know that, but what does this actually mean in clinical terms? So the first thing to say, it isn't this type of illusion. We've already seen the Koenigsegg triangle a couple of times. Actually, that's what I spoke about 20 years ago. It's not that type of illusion. These are hardwired shortcuts that our visual brains make to allow us to see perspective in the world with one eye open or overlapping objects. They're hardwired, and there's no suggestion that as you develop a neurodegenerative disease that they get worse or change in any way. these are there all the time. So really, these are normal phenomena, part of normal vision. Now let's move on to pareidolia. Again, a normal phenomena that we all do. So we can all look at the clouds and see a face. This is a cliff wall outside, or near Hadrian's Wall, a place called Haltwhistle, and you cannot walk past it without seeing faces in the cliff. And again, it's just a hardwired thing that we all do normally. So from that point of view, pareidolia is a normal phenomenon. But we're now starting to get a bit of a clinical angle because we know that it starts to be enhanced in clinical populations. So this is a patient with Parkinson's disease. He's an artist, and he's depicting here how in the course of his Parkinson's disease, he's starting to see faces everywhere. So in stone, I think it's a stone surface and tree barks, etc. So you can see here how there is a kind of a clinical angle to these types of illusions. But what we really mean by illusions in a clinical sense is misperceptions, if you like. So the example here, you're looking at the branch of a tree and you see it as a cat. And in a whole range of these neurodegenerative diseases, these increase in frequency. So patients start to have these much more commonly. Again, I guess we can all do this, but they become very common in the context of neurodegeneration. Now, I'm going to highlight a particular property of this type of misperception illusion, that what's changing here is the category of what is being seen. So cat versus branch of a tree. It's a kind of classification of the object that's gone wrong. And I'm going to call it, in this instance, a what illusion. Now, I want to contrast that with a range of phenomena that occur clinically that we don't necessarily recognize as illusions because we call them something different. And this is the family of symptoms called collectively metamorphopsia. This is one example of a metamorphopsia, palinopsia. So imagine you are staring at this room, you look at your eyes, your gaze falls upon the lampshade, and you then move your gaze and the lampshade remains fixed wherever you're seeing. So this is visual perseveration and one form of palinopsia. Another form occurs when the lampshade becomes doubled. So you have two examples of lampshade. So this is a selective diplopia. Now note, this is different to diplopia that you get in eye disease where the whole visual world will be duplicated. This is just very specific to one object or object feature. And it's kind of a variant of polyopia where you have multiple copies of the object feature and often they form a pattern in themselves. So these types of metamorphopsias, there are others. There are the experience of seeing something further away than it should be or closer, seeing a real face in front of you distorted, or a stationary object that starts to move. So this whole family of illusions, I'm going to refer to as where illusions, because the problem is there's a real object in the world, but the problem is this kind of spatiotemporal understanding of where it is in place or time. And the reason why I'm using this terminology, of course, is because if we look at the major output pathways from the visual cortex, we have one going down into the temporal lobe, which deals with object classifications, and we have one going up into the parietal lobe that deals with visuospatial processing and temporal processing, in fact. And so we can think about these as kind of what illusions, these misperceptions, and the metamorphopsias as where illusions. Now, before we leave phenomenology, I just want to say something about insight and hallucinations. So imagine a hallucination of a figure in costume. And on the left-hand side, we have it occurring where insight is absolutely preserved. So let's say a patient with Charles-Bonnet syndrome recognizes this as a hallucination, chuckles to themselves about the bizarre things that their brain creates. And contrast that with what's happening on the right-hand side, where in this context, it's exactly the same perceptual experience, exactly the same figure in costume, and yet in this context, the patient lacks insight into its nature as a hallucination, believes maybe the neighbour's children have crept into the house dressed up, or that there's some sinister thing going on, and maybe act on the beliefs. There's a whole set of impaired insight and secondary delusions that develop. Now, at the risk of alienating half the audience here, I just want to point out that this is what has been called by some clinicians, and not myself, I would hasten to add, but some clinicians would call this pseudo-hallucination. And the idea here is that it's pseudo because it's not the type of hallucination that occurs in schizophrenia where insight is lost, and so it hasn't got the quality of what you might call a true hallucination. It's a pseudo-hallucination. Now, I'm bringing this up because I'm going to try and persuade you later on in the talk that suddenly, from the sort of a niche kind of phenomenological area, this is going to become center stage in all our clinical practice as we have to think a little bit about insight in hallucinations. So a good place to start if you want to look at this borderland of hallucinations, these marginal phenomena, is Parkinson's disease. And this is a slide showing the spectrum of Parkinson's disease psychosis. Now, I hasten to add that this terminology was made by movement disorders neurologists in the Movement Disorder Society. And so they're using the term psychosis very loosely here because you'll all recognize that many of the things we're going to talk about here are not psychotic phenomena in the way that psychiatrists would mean. But anyway, so we start off over here in Parkinson's disease with the first motor symptoms, sometimes even before the first motor symptom. And you develop early on in the course of disease misperceptions, metamorphopsias, the selective diplopia here, enhanced pareidelias, passage hallucinations, so the experience of usually a figure or animal whizzing by in the corner of your eye, and presence hallucinations, where you get a sense that someone is nearby, a feeling without necessarily a visual or auditory experience. And then as your Parkinson's disease progresses, you developed formed visual hallucinations. It's typically animals or people. And initially, insight is preserved, so pseudo-hallucinations, if you like. And then over here, as the Parkinson's disease progresses, you develop, you lose insight, secondary delusions, hallucinations in lots of modalities. So the question arises, are these bad outcomes that I talked about at the beginning, are they true of all of these phenomena, or are they only true of visual hallucinations, the formed visual hallucinations? So we've looked at this in the Parkinson's Progression Markers Initiative. So for those of you that aren't familiar with it, this is a Michael J. Fox funded big longitudinal study of Parkinson's disease at the point of diagnosis. So these are people first presenting to their neurologist with a motor symptom, and then they're given a battery of biomarker tests and clinical cognitive tests and things followed up. Now I think it's about 5 years. At the time we did this, it was only 3 or 4 years. And it's a freely downloadable database, so you can all do this yourselves. So we divided the cohort into 3. One group of Parkinson's patients, during the course of follow-up, have not developed anything, no illusions or hallucinations. Another group during the course of follow-up have started to develop illusions. So that's cartooned by these the green arrows here. But they haven't developed formed hallucinations, so they're an illusion-only group. And the final group are patients that have developed formed hallucinations. And most of these will have a mixture of illusions and hallucinations, and the formed hallucinations tend to occur after the illusions in this kind of cartoon time course that I showed you before. So just as an aside here, we've all kind of got the intuition that, oh, it's all to do with the Parkinson's medication. This is nothing interesting about hallucinations in Parkinson's disease. So this is just a breakdown of the medication histories of all of the patients that develop formed hallucinations. Here's the point of hallucination onset, and the bars are their hallucination histories. Now, there's a group of patients in PPMI who develop formed hallucinations without any exposure to PD medication. So no dopamine agonists, no L-DOPA, no mixtures of the two. But most of the patients are on medication, but they've been on one of these medications or combinations usually for several years. And on this picture here, I think there's only like 2 patients where you can absolutely say with certainty, well, the hallucination started when the clinician increased the dose of their medication. So there's something else to the story here. It's not just medication, it's an interaction between something that's going on in the brain and their current medications that's triggering the hallucinations. So back to our cognitive question. So here's 3 cognitive domains in the PPMI dataset, Parkinson's Progression Markers Initiative. And the red lines show the trajectory of the patients that go on to develop formed hallucinations. Now note, they haven't developed them at the point that they enter the study, so really they're developing about halfway along the trajectories. But the red line shows you, basically replicates what I showed you in my first slide, that if you've got formed hallucinations or if you go on to get them, you are on a bad cognitive trajectory and they are indicating something that's changing in your brain. But the point of showing you this is the illusion group, and that's the green line. And as you can see, they don't share that trajectory. And not only that, they're not really any different from the patients that don't develop illusions at all, or the normal healthy controls in the cohort. So this is the first kind of evidence that these borderland phenomena, the marginal phenomena that I've been talking about, are not the same in some way as formed hallucinations. And another supporting bit of evidence for that comes from a study of dopamines. We haven't talked a lot about dopamine today, but so it turns out that if you've got low dopamine uptake, this is a DAT scan, dopamine transporter uptake, in the striatum, that predicts future onset of visual hallucinations or future cognitive decline. And again, we looked at this in the PPMI data set. These are the DAT scan uptakes in the striatum at 3 different years. The blue bars are the patients that didn't develop any symptoms, and the grey bars are the ones with formed hallucinations. And so this kind of replicates what we already know from the literature, that formed hallucinations have, or patients at risk of them, have lower dopamine uptake. But the illusion group, again, is no different from the patients that don't develop any symptoms at all. So how do we interpret this? So again, in the same way that Paul was speculating, I too am allowed to speculate. So the idea here is that this family of borderland symptoms have a different pathophysiology to formed hallucinations. And the idea that we've come up with is that it's something to do with brainstem pathology, because they occur at an earlier Braak stage of the Parkinson's disease. Probably it's something to do with inputs that go up to the parietal lobe and to do with eye movements and this kind of function. But it's the dysfunction in that system that leads to these borderland marginal phenomena, whereas it's cortical dysfunction that leads to formed hallucinations, and something specific definitely about the cholinergic system, and also probably in some way, although we don't quite understand why, the dopamine system as well. Okay, so one of the problems with the PPMI dataset is that it doesn't tell you anything about the phenomenology. So you only get one category of thing, illusion, and that contrasts with formed hallucination, with or without insight. So you don't know whether patients are developing one or other of these symptoms. And indeed, that raises the question, well, how do we clinically even ask a patient, have you got metamorphopsia or have you got pareidolia? And are these things that are as rare as hen's teeth, or are they out there all the time and we're just missing them? So here enter the SHAPED study. So this is what we've been working on over the last 8 years or so. It's an NIHR-funded program grant study of hallucinations in Parkinson's disease, eye disease, and dementia. And like PPMI, we have cohorts of patients that we follow up. Some have hallucinations, some don't, in each of these different conditions. And unlike PPMI, we do detailed phenomenology. So it's a kind of semi-structured interview. So it basically mimics what we do in the clinic, and it's about listening to the patient, hearing the story, and then deciding yourself what type of borderland phenomena or hallucination the patient is describing. So now, I'd kind of expected to be able to read this from my plinth. So excuse me, because I'm going to go just down here. So just imagine a patient tells you a pillar in the window looked like a body. So we'd all agree, oh, that's a misperception, that's one of these what illusions. We wouldn't get that wrong. But so when a patient says, sometimes when looks at objects, thinks they've moved or appear to be moving, so that's a metamorphopsia, sees bedroom as being all jumbled up, e.g. wardrobes standing on their side, various other furniture placed on the bed and in odd places around the room. Real furniture, wrong locations, metamorphopsia. And then pareidolia is again fairly obvious, patterns in curtains turn into faces. So it turns out that in the Parkinson's disease group, and that's across the whole spectrum from cognitively intact Parkinson's right at the beginning to Parkinson's dementia, between 20 and 30% of patients reported phenomena like this. So the take-home message is these experiences are out there in the clinic. It's just that we're not sensitive to them, we're not picking them up, we are not recognizing them when we're told about them. So just a few words on pareidolia, because it's being converted into a clinical test now, and designed initially to detect dementia with Lewy bodies. And in the original formulation of the test, it was these naturalistic scenes that were presented, and patients were asked to say, well, in the background, can you see any faces or animals or anything odd? And they sort of see faces in the leopard spots and on the flowers, etc. And here's the first study showing dementia with Lewy bodies, much higher rates of pareidolia compared to Alzheimer's disease or healthy controls. Now we've done this test in Shaped as well, and a different version of the test, the pareidolia noise test. So it's now visual noise patterns, and some of them have a face in. Hopefully the face pops out for you. But the real test is about these stimuli where there's no object in it, and if you have got dementia with Lewy bodies, or if you're experiencing pareidolia, you see every sort of little patch, you see a face everywhere. You don't need a lot of prompting to see the faces. So on the one hand, this kind of supports the previous evidence, but what Shaped found was that this is actually a general propensity across all of the conditions. So it doesn't matter if you've got dementia with Lewy bodies. If you look at Parkinson's disease, for example, so these are the blue bars are the patients who aren't susceptible, who aren't experiencing visual hallucinations clinically, and these are the ones that are, and you get higher rates of pareidolia in the hallucinators, and that's also the same in eye disease, in the dementias, or in these comorbid conditions where you've got eye disease and dementia, or Parkinson's disease and eye disease together. So pareidolia, at least, seems to be some kind of general thing, a general marker for hallucination susceptibility. And it may kind of represent something more along the lines that Paul was just talking about a general kind of model that's true of all hallucinators, etc. A mechanism that's true of all hallucinators, but maybe distinct perhaps from some of the other borderland phenomena I was talking about. Okay, I just want to end by saying a few words on treatment. The real purpose of Shaped was to develop guidelines for treating visual hallucinations across all of these conditions. Try to have a kind of a transdiagnostic approach that would apply to anything and kind of tap into the ways it's treated in Parkinson's disease and eye disease and altogether, etc. And this is the guidelines that have come out, and they've just been accepted by JNNP, thank you, and they're going to come out later in the year. And I don't want to dwell on the details of the algorithm, but just some broad details. So we start treatment of visual hallucinations before the symptom has even started by forewarning people in these conditions. And when the hallucination starts, that's this point here, we have as we all do, but in a more formal way, a general health physical review, a cognitive health review, and an eye health review, and a medication review, just to make sure you're not taking anticholinergics and stuff. And then, so not everyone with hallucinations needs actual treatment. So for most people, you don't need to dive in with clozapine. You can stay at this stage. It's only at this transition point when hallucinations become a clinical problem that you need to think about treatments. And for the different options, you've got the whole range of medications tackling different neurotransmitter systems, mostly based on case report evidence rather than clinical trials. One new thing for Shape was emphasizing that the carer, if there's a carer, they need treatment as well, because actually at this point the burden of the hallucination falls upon the carer from the patient, and there are psychological treatments as well, etc. But I don't really want to dwell on that. I want to focus on this key point here. When do you start treatment? What is it about these distressing hallucinations? And it turns out that this point is where insight starts to become impaired, fluctuating or partial insight. So what does that mean? It means that the patient at the time that the hallucination occurred phones the police or ambulance. But by the time they come to clinic, they laugh at it and say, oh, what a crazy thing that was, etc. And so they've regained insight, or they can be prompted to regain insight. But every time the experiences occur, they still behave as if they don't really fully understand it at the time. So that is the key point at which, as clinicians, we now need to start to think, hang on, I'm moving down the algorithm. We need to start thinking about treatment now. And the reason why I dwelt on insight earlier was, of course, because that is the transition from pseudo-hallucinations, if you like, to true hallucinations, or hallucinations with insight lost. And so suddenly, this is something that we're all going to need to be thinking about. So just my final slide here, just to say that I guess two key take-home messages are that these borderland phenomena collectively probably have a different mechanism to formed hallucinations. There's a different pathophysiology. And whether they all represent one thing or lots of different things, in other words, is the mechanism of passage hallucinations different to metamorphopsias, for example? That we don't really know that yet, and that's questions for further study. But what is clear at the moment is we all need to make an effort to pay more attention to phenomenology in the clinic, to really understand what our patients are experiencing. Because it's only by doing that can we help predict what their future trajectory is going to be in terms of outcomes, and also, critically, at what point we need to start treatment. I thank you for your attention.